What is an HSG test and what should you expect? Hi, friends. I'm Dr. Natalie Crawford. I'm a board certified REI and OBGYN, so I'm a fertility doctor. And every day I talk patients through what they need to know about their body, health, and their hormones. Today I'm talking about one of our fertility tests, the HSG or hysterosalpingogram. Before I dive in, I just want to say thank you guys so much for being here. As this channel is growing, I love seeing your comments, your questions. You really fuel the next topics that we cover. So keep it up. And as always, subscribe, share, like, and make sure that you check out the Fertility Formula, my book, if you want to learn more. An HSG test is one way that we evaluate the inside of the uterus and the fallopian tubes. It's really important to understand that a regular vaginal ultrasound actually does not provide the entire picture. This surprises so many people every single day. The way I like to think about it is to imagine your uterus as a potential space. So we always think about the triangle shaped wall of the uterus that we see in pictures with a central cavity. But the reality is those two walls are against each other when the uterus is just in its resting or normal state. So that means when I do a vaginal ultrasound, I can see the walls of the uterus pressed against each other and the inside of the cavity is connected. This means I can't see inside the uterus and I can't see the fallopian tubes on ultrasound. The analogy I like to give is to imagine, I'll take my AirPod case for the example, on vaginal ultrasound, let's say you have a polyp. Well, I might not see it on vaginal ultrasound because I don't see inside the uterus. But if I go put any type of liquid in the uterus and push the walls apart, now I can see that something is abnormal. And HSG is not going to tell us exactly what this is, but it's going to fill the uterus with fluid, and you can have what we know as filling defects, or you can see where the air pod is wouldn't fill with fluid. Whereas if I didn't have that, the entire cavity would fill with fluid, and you would see that nice inside of the triangular shape. So the reason we do an HSG is to see the inside of the uterus and the fallopian tubes, because that dye will move through the fallopian tubes and will come out the ends if they are open. This means an HSG test is really important to confirm normal anatomy. It can help detect uterine birth defects, polyps, fibroids, scar tissue, and it can show tubal obstruction and also tubal dilation, known as a Hydrosalpinx. So it's an extremely valuable test. But there's a lot of confusion and a lot of fear about it. And I think that's because we've not done a really great job of talking about women's health or talking about pain conversations. So for most patients, what should we expect with the HSG? One of the hard things to do is to actually time it right, because what we have to do is get the dye into the uterus when the lining is not super thick. Let's just think about if the lining is very thick, it can mask abnormalities and it can make it hard for the dye to get into the fallopian tubes. So we have to time it purposefully after you bleed, but before the lining thickens up as you get close to ovulation. This is why if cycle day number 1 is the first day you start bleeding, we time the HSG test between cycle days 6 to 10. So this will always be scheduled within your cycle prior to ovulation. Asterisk. If you're on birth control pills, that will be different because the lining will constantly be kept thin and you're not ovulating. So we do have more flexibility. On test day, you will notice it starts out like a pap smear. A speculum goes into the vagina. The cervix is seen. A small catheter is easily placed through the cervical opening, and then dye is injected into the cavity. The uterus will separate a little bit. This will feel like a menstrual cramp. So in almost everybody, you feel that full feeling inside the uterus, and then the dye will move through the fallopian tubes. Most people will say that it's a quick, maybe intense menstrual cramp lasting less than a minute. But there's exceptions, and you should think about them. So patients who've got a blocked fallopian tube, this definitely can cause some pain. And just think about it. I'm pushing fluid against something that's blocked. So what's going to happen? All that fluid is going to back up and distend the cavity even more than it should be. And that is obviously going to be painful. The other exception is sometimes people will use a tenaculum to grab the cervix for the test. Now, I don't do this and I haven't done this for a long time, and many of my peers do not, but it's worth asking the question about what they're doing, if they're using something sharp to grab the cervix or not, because that would obviously be painful if that is how they are doing the procedure. You can ask for local anesthetic if they're going to use a tenaculum. So obviously, we want whoever's doing the procedure to feel comfortable doing it. But if they need the tenaculum, maybe they can inject local numbing medication before they grab. Yes, numbing medication can cause a burning feeling, but that can often be better than the tenaculum itself. You can also ask if this is a clinic or a place that can help and use other options. Is Valium an option? Is nitric oxide, a gas, an option? Doesn't mean you should have to, but you should ask about it. And then who's at higher risk? if you've had a prior ectopic or tubal pregnancy, if you've had prior tubal surgery, if you have known or suspected endometriosis, or you've had other bowel abdominal surgery, ruptured appendix, a lot of GI issues, higher suspicion that something might be wrong with the fallopian tubes. And so we might want to consider at least having that discussion about what to expect ahead of time. After the HSG, what do we do with this information? Well, you will note that most of the time you are given a short course of antibiotics, and that's because pushing fluid through the uterus out into the peritoneal or the abdominal cavity does pose a small risk of infection. So please take all the antibiotics if you're given them. We then will follow up with what you do. So if there's a filling defect in the uterus, that means the dye didn't go everywhere. This has to be evaluated further. Sometimes it could be a blood clot, or maybe the lining was thicker. This can be followed up with either a saline sonogram, so very similar, but it's just saline, and we watch with ultrasound. A saline sonogram doesn't give us information about the fallopian tubes. That's why we can't do it for complete testing. But that can help evaluate if a filling defect is a polyp or a fibroid or a blood clot or what could be going on. Then we also could say, instead of a saline sonogram, we could do a hysteroscopy. One of the advantages of a hysteroscopy is it's a see and a treat. So diagnose and it's therapeutic. Hysteroscopy is a small surgery where we put a camera through the cervix into the uterus while you have anesthesia, and then we can actually see the inside of the uterine cavity and we can remove polyps or anything that we might see. Now, this is the gold standard for uterine cavity evaluation, and this might be where your care team wants to go if they do see a filling defect on HSG. For the fallopian tubes, as long as you have one tube that's open and normal, so the dye comes out the tube and exits, you're good to go. You may not realize, many people don't, that the fallopian tubes actually move around in the body. So as long as you have one that's open, even if you ovulate from the other side, the tube can move over and can get that egg. It's fascinating. So as long as you have one tube open, you have a great chance of getting pregnant naturally or with ovulation induction or IUI, depending on your age, semen analysis, and other factors. If both tubes are blocked, then we have to have a different discussion. And where the tubes are blocked and if they are dilated actually matters a lot. So the different types of blockage, one can be proximal and one can be distal. So proximal is at the opening. So think where the tube meets the uterus. Distal is at the end of the fallopian tube. Distal blockages are always pathologic, meaning it's a problem. Some type of inflammation, infection, blood, something happened. Distal blockages are from a problem. Proximal blockages can be either. So you could have scar tissue on the inside of the uterus, or you could have spasm of the tubal opening. And so sometimes for a proximal blockage, we can't make a full decision based on what we're seeing, because if the dye is injected really quickly or hard, sometimes you can get spasm of that tubal ostia or opening. This might be a circumstance where they say, hey, we should repeat this again, or we should look with a different form of observation. Sometimes we can do a FIMBU or a bubble test to see if you're going to surgery for other reasons. Sometimes they can put a little catheter into the tube and see if they can get the dye past it, or just looking at surgery. So it might depend on the full picture. Distal blockages are, quote, real, but if the tube is dilated and it's called a hydrosalpinx, then we're extra concerned about that. So for a hydrosalpinx, a blocked and dilated fallopian tube, we know that even if the other tube is open and looks normal, you now have a 50% decrease in your chance of pregnancy across all treatments. And the reason why that's important is even if you're doing IVF, we have to surgically remove hydrosalpinx. We have to sever the connection somehow between the tube and the uterus. And the analogy I think about here is if that tube is dilated, your tube actually makes secretions, which are normal, and they usually go out the end of the tube. But if the end of the tube is blocked, the dilation is the backup of those secretions. And then where are they going to go? That is going to leak into the uterus. And so it's like stagnant water that's going to get icky and then drip into the uterine cavity. And this is why we see that decrease in pregnancy rates. And you might even notice some weird vaginal discharge from a hydrosalpinx. It's typically very liquidy, sometimes could be pink or brown or clear, but it's very liquidy discharge that doesn't make sense for where you are in your cycle. So if you have a hydrosalpinx, it does have to get removed. You would be shocked how many patients even go through IVF and never have their fallopian tubes evaluated. And we're only finding out they have a blocked, dilated tube when they've had prior failed embryo transfers. It's really unacceptable. Understanding your uterus and your tubes is part of a standard fertility evaluation. And even if you're fast tracking for IVF for some reason, understanding your tubal status is important before an embryo transfer, since hydrosalpinx do decrease pregnancy rates. Okay, would love to hear more. I know that everybody has a different experience with an HSG, and I'm not trying to minimize it, but I do want to stress that I order these on almost every patient, and the vast majority said that the fear of the procedure was worse than the procedure itself. So hopefully that gives you some reprieve if you're worried about it. And if you have risk factors or you're curious, at least giving you information to open up a discussion with your care team. Thank you guys so much for listening. Ask your questions below. And as always, you can get more information on Instagram at Natalie Crawford MD, the As a Woman podcast, or check out my book, The Fertility Formula.